Next, I would like to invite NP Hannah Berg, who works together with Dr. Anthony Tofaro in surgery, so she can share with us some of tips on how to get better after surgery. Thank you very much, NP Berg.
So for those of you who don't know me, my name is Hannah. I'm a nurse practitioner here. Some of you had care with Dr. Gassman. I now work with Dr. Tofaro. And my background is plastic surgery, but I specialize in melanoma and do melanoma surgeries with Dr. Tofaro. So my topic today is to discuss, and a lot of you have probably already been through your course of melanoma with us, had surgery already, but this is tips for recovering after surgery. So any people who are watching and haven't had surgery yet, kind of give you the expectations of what that visit's gonna be like. So for your first appointment, and this part to me is so important, the first appointment is a consult. A lot of times we'll have people think that they're coming to us and having surgery at that first appointment. It's a consult. We need to meet with you, review your pathology, get to know you, and start building that trust because we are going to be operating on you. At this appointment, you typically come to us from dermatology with your biopsy already done. So we're going to review that pathology in detail to talk to you about what surgery we're going to offer you. And then we're going to start that process of talking about staging what's next. And I think one of the most important things just presenting here in front of everyone is everyone has a different journey. They're coming to us at a different point of their diagnoses. So I'm kind of starting this from the beginning. You went to dermatology, you had your biopsy, and now you're meeting us. Okay, so at your first appointment, this is the important piece of paper. This is your pathology report. And this is going to determine the surgery we're going to talk to you about. So breaking this down, there's the tumor type, the Breslow, which is the depth, ulceration, mitotic rate, which is how fast are these cells replicating, and the margins. To keep it simple, the Breslow to us and the margins is very important and is what drives your surgery. So the Breslow is the depth of that tumor. How deep is it going into your skin? This determines if we need to find out, are there lymph nodes involved? Will you have a sentinel lymph node biopsy? And we offer and strongly suggest a sentinel lymph node biopsy for anything greater than 0.8 millimeters or higher. We also look at the margins. You had a biopsy. A lot of times I say a biopsy is just kind of like taking a tip off the iceberg. They're not getting, a lot of times, all of the cancer. So you do have to have that lesion re-excised. So what surgical procedures are we going to offer you? So most patients are going to get offered the wide local excision, which is the actual surgery part of removing the cancer on your skin. And it's important for us to obtain the correct margin. So for any any Breslow 1 or below, it's a 1 centimeter margin. And then if it's higher than 1, we get 2 centimeter margins in each way. The sentinel lymph node biopsy is us checking to see, has cancer spread to your lymph nodes? So at your day of surgery, your melanoma, so say you have a melanoma on your shoulder, will be injected with a tracer. That tracer starts going into your lymphatic system. You get a quick little scan and it tells us if cancer were to spread, what lymph nodes would they go to? How does our surgeon know where to look? We then follow that tracer, and then in surgery, we have all the special equipment that tells us which exact lymph nodes to remove and biopsy. There's also something called a lymph node dissection, which isn't necessary for a lot of people. This is where we remove lymph nodes. Oh no, my typo's in here. Lymph nodes where a mass is, or if someone had a positive sentinel lymph node biopsy and they're not responding to treatment, they might qualify for a lymph node dissection. We typically see this in the axillary, neck, and groin. And then reconstruction. So anytime from a surgical point, we're making a hole, we're cutting, we need to know how are we going to close this and make patients happy. Our outcome is we want you to be comfortable with how we closed your surgery. So there's primary closure, skin graft, and then there's a bunch of flaps. The most common one is an adjacent tissue transfer, and then the most complex is a free flap. So before your procedure, you see us. Our surgical scheduler will then call you, get you set up for your surgery, and then pre-anesthesia. Pre-anesthesia is the appointment you need to have to make sure it's safe for you to go to sleep. They're going to review your medications, your lab work. If you have blood thinners, we need to know about that because we need to stop blood thinners, and we need to get clearance from your prescriber. Nothing to eat or drink after midnight, and then please have a ride. If you're going under anesthesia, you need to have someone take you home. After your procedure. So this first one, try your best to rest and relax. We understand you just went through something, life-changing, a big procedure, you're uncomfortable, and you're also anxious. And we get that. You're waiting for your pathology results. So I tell people, try your best to take it easy, distract yourself, because the pathology really does take 7 to 10 days to come back. Hopefully, you guys got a nice packet at your discharge that has follow-up instructions and just basic wound care. It's not always perfect, those instructions that you're given after surgery. So if you have any questions, call our office. We're happy to go over that with you. In that first week when you're waiting to come see us for your post-op, if anything is wrong, even if you just want to talk, call us, because that's my job. That's what we're here for. We're here to get you through this healing process, and we want you to know that you're not alone through this. So even if it's something as simple as, bruising, let us know, send us pictures, and that's why we're here. Post-op care. So I kind of broke this down into 4 different segments. We have wound care, pain management, monitoring for complications, and JP drain care. So at your first post-op, we'll review your pathology and discuss the plan moving forward. We'll talk about wound care, pain management, and answer all your questions. So for pain management, the first line of defense we tell everyone is, if you're allowed to take Tylenol, we recommend extra strength Tylenol, which is 1,000 milligrams, every 6 hours for pain as needed. You will also be prescribed, unless you told us that you do not want this, a narcotic like oxycodone. And typically that's also to be taken every 6 hours as needed. What I tell patients is stagger it. So say you're having 8 out of 10 pain. Take that oxycodone. 3 hours later, if you're still having pain, take Tylenol. That way you're getting something every 3 hours, and you're hopefully more comfortable that way. Another option is ibuprofen. I always tell people ibuprofen is a blood thinner. From my experiences, we tell people you can take ibuprofen and you can start staggering that in as well. Wound care, Aquaphor. That's my favorite thing in the world. So you had surgery. We typically tell people you're okay to shower 24 to 48 hours after surgery. You can get your incisions wet, take off those bandages, unless you have a special bandage called a bolster or a wound vac. We recommend kind of scrubbing around the area and then letting that soapy water trickle down and pat dry. We always tell people baby shampoo or any unscented soap. Typically for the first 7 days, we'll have you apply antibiotic ointment like bacitracin, neosporin. Anything past 7 days, I just don't recommend, because you can start the skin can start turning red and doughy, and it can almost look infected. So we kind of stop any ointment at 7 days. After those 7 days, you get to start Vaseline or Aquaphor, and hydration is going to be your best friend. My joke is, I don't know if anyone's seen My Big Fat Greek Wedding, and the girl gets a zit and they say, just spray a little Windex on it to cure the zit. That's Aquaphor for me. When in doubt, put Aquaphor on. A lot of times patients will ask, do I need to keep my incision covered? I say for the first 3 days, yes, because you're probably going to be having some drainage. But once the drainage stops, it does not need to be covered unless you're doing something active and it can get dirty. And again, your wound care will be based off the surgery you have. Okay, so this is a primary closure. So you can see here, the first picture is they had a melanoma on their back, and then they had a sentinel lymph node biopsy. So this is the typical kind of closure. We were able to pull the skin together, and that's called primary closure. The biggest thing, and I think we touched base on it yesterday, is why is your incision so big? You came to us with a lesion or a biopsy site that was the size of a pencil eraser. That all has to do with margins. So, like I said, the margins are going to be anywhere between 1 to 2 centimeters in all directions. You're going to have a circle. We then have to turn that into a football shape so that we can close it in a single line. So we tell people that the incision length is going to be 3 times the size of your the depth, like the hole that we made with our margins. With closing this, sutures may be absorbable or they may need to be removed. How long the sutures stay in place depends on the location on your body. And then looking at this, I just want to point out, because I'll talk about this a little bit later, you can see there's some redness on these incisions. And a lot of times, a lot of people will think, oh, infection. This redness here is normal redness. You're going to have redness because of suture irritation. Your skin doesn't like having something irritating it. It's going to get a little bit red. I'll talk more about what to look for with infection later on. A common complication that I will see is something called a retained suture or suture abscess. So in this picture, you can see those 4 areas of crusting almost. Essentially, what this is an absorbable suture that hasn't fully absorbed, and it's migrated its way to the surface. It can be very irritating, little tender to touch. They typically will work its way out and kind of fall out. But what I tell people is, if it's bothering you, call us. You can come in, I can remove the suture, and then just put a little bit of antibiotic ointment for about 3 days. We also recommend massage. Massage is key in this whole process of scar healing. Massaging that can help break down that scar tissue. Another complication is a wound dehiscence. So that is a separation of the wound edges. It can be partial or total. So here you can see it's partial, it's not the whole incision. If this happens, please reach out to your team ASAP. It's not an emergency, but it needs to be cleaned. We need to change your wound care, and it will be a wet to dry dressing. And debridement is sometimes needed, but that's pretty extreme. Okay, so one of the most popular types of closures that we use is skin grafting. So this is used in an area where you can't pull the skin together. So think face, feet, sometimes the forearm. And there's 2 types. There's full thickness, where we take the full thickness of that skin, or split thickness, which is just part of the skin. When you have a skin graft, you're going to have a bolster dressing or a wound vac for the first 7 to 10 days. While you have that bolster dressing on, that basically is just a rolled up piece of lubricated gauze that's sutured down. I have a picture of it in a second. And you don't really need to do anything, except sometimes we have you put some Vaseline around the edges. Once the bolster comes off and the wound vac comes off, it's all about hydration. So you're either going to apply Adaptic or Zeroform, which is that lubricated gauze, or Vaseline and Aquaphor to the graft and cover it with gauze. Again, keep the wound hydrated. That's keep it simple, hydration. So this is what skin grafts look like. And if you've never had one, it can be kind of scary at first to look at. So the first picture all the way down is a picture of a patient where I just took off his bolster dressing. And, it's easy to look at when it's not you, but it does look like a little crater. It's not pretty. The next picture, after doing some wound care, is about 3 weeks later. You can see that it's starting to fill in. I don't have his final picture yet because he's still in the process, but this is all just from keeping the area hydrated and massage. And then this last picture is a skin graft on the scalp. So you can see on the right-hand side, there's normal kind of scarring there. And then there's that little red and yellow area. So the red is something called hypergranulation tissue, which is just overgrowth of the healing tissue. And then that yellow is fibrinous tissue. So if this happens, you see this at home, send us a picture. We'll bring you in. We'll kind of lightly pull off that yellow tissue and then use some silver nitrate to kind of kick back and slow down the healing in that pinky area. But our goal is to make this look flat. Like, you're gonna have a scar. Anytime we're doing anything, you're gonna have a scar. But by treating it with hydration and massage, it can really start flattening out. So tips for your skin graft, again, hydration. Expect color changes and scabbing. If that happens and you're, in between your appointments and you're worried, reach out to us, take pictures. Pictures mean everything to us, so send them to us on my chart. We'll call you and get back to you if there's something concerning. You can get the graft wet, just be gentle when washing. Some grafts fail, especially on the lower extremities. It's the furthest thing from your heart. So if your graft fails, it's not the end of the world. We'll be disappointed, but you'll heal from the inside out and you'll still heal well. And then when in doubt, send us a picture. So this is an example of a bolster dressing. So bolster dressings are used over the skin graft. Essentially, the purpose is to hold skin grafts in place and prevents fluid accumulation so that your skin graft can fully take. Stays on for about 5 to 7 days. We take it off at your first post-op dressing or first post-op appointment. If you had a skin graft on your leg, sometimes the arm, stomach, you'll get a wound vac, and the purpose is the same thing as the bolster dressing. I will say wound vacs are the things that make our patients the most unhappy because there's lots of beeping, a lot of think times, you have to charge it, the suction doesn't work, but we give you this nice booklet with numbers to call if that happens. But yes, we take this off at the first post-op as well. And then briefly, rotational flaps, adjacent tissue transfers. This is used when primary closure is not an option and that we don't want to use a skin graft. It's essentially pivoting of the adjacent tissue skin around an axis to close a wound, keeping blood flow. For this, I just want to touch base. The most important thing is monitoring the color of the flap. Make sure it's not turning dusky or gray because that could indicate that there's not adequate blood flow. The skin should appear normal skin color, but remember, it's post-op, you're gonna have bruising and some redness and swelling. And temperature should be warm like the surrounding skin. So this is an example of a rotational flap. You have the deficit, and then you can see, like, why does he have this big Z scar? It's using all the skin to kind of flap over it, and then this is how he's healing. So it looks really good. Another, I call everybody, this is your little buddy for a while, the Jackson-Pratt drain or JP drain. So this is used to collect fluid from a surgical wound. You typically will see it in patients who had a sentinel lymph node biopsy or an axillary dissection or groin dissection. This allows the body to heal faster by pulling and collecting all that fluid and not letting it sit in the body. It also helps prevent seroma, which is a fluid accumulation, and infection. These stay in place until the output is less than 30 milliliters in 24 hours. We used to say 3 days, now we do about 1 to 2 days. So expected findings after surgery. Mild redness at the incision site, bruising, swelling, small amounts of oozing, and fatigue. When to reach out to us. Any signs of infection, fevers, chills, purulent or pus-like drainage, foul odor. If all of a sudden you're having increased drainage, increased pain, if you start developing hardness around the wounds, that could indicate a hematoma or seroma, any redness or warmth, and any color changes to the wounds. If anything is changing and you don't expect this, call us. Like, that is why I'm here. I'm here to be like a resource for you if you just don't know or you have a question about, is this normal? Infection, these are just some pictures of what infection looks like. We typically will do a wound culture, start you on oral antibiotics, and your wound care may change. A seroma, this is a very common complication with people who had a sentinel lymph node biopsy or the dissection, complete lymph node dissection. It's an abnormal accumulation of serous fluid in dead space. And basically, we disrupted your lymphatic system. That fluid doesn't really know where to go. So sometimes we already put that drain in place to prevent this, but there's other times where we don't. Often the body will reabsorb the fluid on its own. We'll do an ultrasound. Sometimes we try compression, and then we also do aspiration and drainage. And this is a good picture of it. You can see that right there on the side, that is a fluid accumulation called a seroma. Post-op activity, take it easy. Please don't go golfing the next week. Don't lift anything heavy. Like, you just had a big surgery, rest. We tell you not to lift anything greater than 10 pounds for the first 2 weeks. Then start adding in activity gradually. Please, no swimming, hot tubs, baths for at least 4 to 6 weeks. That's sitting in, even if it's your pool, it's still dirty water, and you're just kind of sitting in there, and that's asking for an infection. I tell patients, let's have a diet high in protein and make sure that you're drinking enough water to heal. Lifestyle changes, sun protection. Dermatology just talked about this, but I also tell patients your dermatologist is going to be your best friend. You're going to be seeing them every 3 months for the first 2 years following your diagnosis. After that, every 6 months for 5 years, and then yearly for the rest of your life. All right, and lastly, what are the next steps? You made it through surgery. So these next steps go back to the pathology from your surgery. Your surgical team will follow you until you're healed from surgery. If you don't qualify for medical oncology, we will follow you for about 1 to 2 years post-operatively, and this may include some imaging. Every patient heals differently and has different needs. Our medical oncology team, we all sit right next to each other, so we kind of approach each patient as a multidisciplinary approach. So we'll refer to medical oncology if your pathology from surgery indicates a stage 2B or higher. So if you had a positive lymph node from that lymph node biopsy or anything, if your primary tumor was super, super deep, you're going to be referred to them. When we refer to oncology, we get the baseline images, which is our CT, chest, abdomen, pelvis, and a brain MRI. And then sometimes we will refer if there's a family history of melanoma too. And then, like I said, dermatology, you're going to be going to them quite regularly. But I also tell people, if in between those appointments you see something abnormal, you see a skin change, let us know so we can get you in faster for a biopsy, because the patient is the first line of defense. Key takeaway, your pathology determines your surgery. It's completely normal to feel anxious through this whole process, and we're here to guide you and support you in any way that we can. And then, I think you guys know this, hydration is your best friend. Aquaphor and stay hydrated. And just know, we're a great group of providers here, and we care about each and every one of you. So whatever you need, please come to us. We're here to help. That's it.